guys, Carmen here. I just wanted to bop in here real quick and personally thank you for taking the time to participate in this lecture. The root cause resolution is my newest parent lecture, so I'm really excited to be bringing this material to you. I will be going in and out on the camera here just because I think it's less distracting. Plus, sometimes my image tends to cover upwards, so we don't want that. So I'll be in and out, but more importantly, I just wanted to thank you for taking the time because it shows that you obviously are concerned about helping your child thrive. So I think we should go ahead and get started. All right, guys, so here we are, root cause resolution, helping you find the root of the problem so your child can thrive. In this parent masterclass, I am going to show you how myofunctional impairments can affect your child and why finding the root cause is so duper very important. By the end of our time together, you are going to learn 6 things that every parent should understand about craniofacial development. But first, who am I? I said I'm Carmen, but who am I? And why am I qualified to be teaching you here today? So you may have followed me for years, or you might be completely new to me, but let me tell you who I am and why I'm qualified to be teaching you this information. Like I said, my name is Carmen. I have a large global myofunctional therapy practice. I have founded the Myofunctional Therapy Training Academy, where I teach ambitious dentists, dental hygienists, speech therapists, how to screen for myofunctional impairments, how to implement them into their daily practice. And I am also excited to say I'm a speaker on all things myo. By training, 2 of my degrees are in dental hygiene. But let's talk about what gets overlooked in the dental office. So much gets overlooked. You guys, root cause of snoring gets overlooked. The root cause of red, swollen, nasty gums. The root cause of dental decay and perio problems. Toxic oral habits get overlooked. A lot of times early intervention for crowded teeth, misguided craniofacial growth, they all get overlooked. So let's talk about why I pivoted to become a full-time myo slayer. You guys, it is because I couldn't stand to see dentists with their antiquated and ignorant way of thinking. Now, I spent 16 years in the field of dental hygiene before I decided that I needed a pivot. After learning about myofunctional impairment, I learned that most, if not a majority, of the dental world was way behind the times, and I was really being stifled under the thumb of a dentist who was more impressed with her Lexus than with screening for tongue ties or sleep apnea. Now, she sold a lot of Band-Aids to patients, such as night guards and snoring devices, but she never helped look for the root cause. She never helped look for resolution, why something was happening. So that's a little bit of the story, why I'm here today. Now, if I'm new to you, I want you to know that my path of passion is to be a voice for kiddos because parents just don't know. I have spent thousands of hours speaking and educating on this topic, and I will warn you that sometimes I do get a little fired up over this stuff and I dish up some parental tough love, but it's all for a good purpose, the health of our beautiful children. We can't help them be extraordinary humans if we overlook some of the most important issues. Now, I know many of you are here because you want to learn about my special bridge program called Mommy, Myo, and Me. And I'm going to talk about that opportunity at the end, but in the meantime, I encourage you to take notes as I teach so that you have them to refer back to. Now, I did create a workbook for you, so you can go grab it. Right there's the link. You can get that at carmen-woodland.mykajabi.com/root cause resolution. Okay, guys, let's jump into it. Root cause resolution, helping you find the root of the problem so your child can thrive. So first, let's talk about orofacial myofunctional therapy, OMT. Some people call it orofacial myology, myofunctional therapy. They're kind of all the same thing. So, but what is it? I like to say it's like physical therapy for mouth and face muscles. We work to rehabilitate muscles of the orofacial complex. We work to look for root cause resolution rather than band-aids, you guys. That's what we do. We try and get away from that silo mentality and look at all things. Now we work on tongue strength, we work on coordination, we work on neuroplasticity within the brain, so those neuromuscular connections. And really the 4 goals of therapy are correct tongue posture, correct mouth posture, swallow correct and normalized, and nasal breathing being the preferred method of respiration. So when we're thinking about solving problems, we're thinking about not just putting a Band-Aid on them. So I like to educate parents about 6 predominant areas. So I lecture a lot on the 6 things that parents need to know about craniofacial development in their child. But first, what is craniofacial development and what is good development? Craniofacial development is the development of the head and face. Good development is enough growth forward so that there's adequate bone for all of the teeth to erupt without being crowding, without being stacked on top of each other. Good development is forward so that the airway has maximum volume and the tongue and the tonsils aren't in the way so that they're not an obstacle. And also so the palate develops nice and wide so that the roof of the mouth is not living high up in the nasal cavity in the sinus area, okay? So let's get ready to jump in. So, number 1, let's talk about airway awareness. Your child needs air. Having an eye for an airway concern can be life-saving and can mean a huge advantage for your child. You guys, snoring is not cute. Mouth breathing is not cute. Gasping is not cute. These are all sleep disordered breathing. Another thing that's not cute is swollen, nasty tonsils. When somebody has these swollen tonsils, it makes the space smaller and it creates an obstruction for air. Now, I get it. I understand that you want to avoid surgery or you want the tonsils to be left to do their job, but you guys, your child also needs air so that the air can do its job. And to me, having adequate air is more important than keeping the tonsils. Now, a common question is that, parents will reach out to me and they'll say, hey, will the tonsils shrink if my child starts nasal breathing? And the answer really is yes, potentially, but we usually can't establish nasal breathing when your child can't get air. So it's like a hamster wheel. You can't just tape your kid's mouth shut. That is a huge Band-Aid on a bullet wound, you guys, and we don't want to do that because it can traumatize your child to the point that they do not want their lips closed. Taping the mouth shut does not change the habit. So we definitely have to observe removing the obstruction so that your child can get air. So what can you do with this information? You can observe your child. So I would love for you to grab your kiddo and look at him or her from the side. Do you see a recessed chin? So if you look at the nose, lip, chin, do you see that it's going backwards, okay? Also, does your child snore or gasp or have poor sleep? What about grinding the teeth? What about bedwetting or behavior issues? You know, a lot of children that have sleep apnea concerns, they grind their teeth, they're not sleeping well, they are having behavior issues. A lot of children are getting labeled and medicated as ADHD when you guys, they just need a good night's sleep and they need some oxygen. So definitely something to tune into. What about night terrors, restless sleeping, sleeping in funny positions? Does your child sleep with the chin tipped back? We call that self-CPR because, when we're doing CPR, we're tipping the chin and we're opening the airway. So does your child do that? All of these things are big, gigantic red flags for sleep apnea. Now, at the end, we're going to talk about what I want you to do, but I want you to know this. Your child doesn't have a voice in this, which is why I get so fired up over it. You wouldn't ignore if your child had a rash on their arm or a broken arm, so you don't want to ignore airway distress. When your child doesn't breathe right, the face does not grow right. All right, guys, so now let's talk about tongue ties. Number 2 is tongue ties matter. So what is a tongue tie? Let me see if I can bebop on the screen here and just kind of come right in here and talk about this. So the first thing, you guys, is what is a tongue tie? So, and this is not a fad. Tongue ties are there at birth. The problem with a tongue tie is that they're just not black and white. Some countries screen for them at birth, others not so much. I can see where that would be great, but on the other hand, I see where it would be difficult because who's going to enforce it, right? So we all have tissue under our tongue that's called the frenum or the frenulum, okay? Some people, that is in the wrong spot. It's too short, it's too thick. Maybe it's inserting out towards the tip of the tongue. Perhaps it's really, really short and it's more posterior and it prevents the back of the tongue from lifting. That's the hard part, is because there's so many variables. I teach my students, hey, we need to have common sense when it comes to this, and sometimes there just isn't any. And so while they're not black and white, it really is important that they need to be identified and fixed, okay? And so how do they get identified? And you'll probably hear me talk about this potentially multiple times in this lecture. They have to be identified based on how they're affecting oral function. So just going to the doctor and having your tongue sticking out basically only tells you that the genioglossus muscle is working, because that muscle only goes forward. And so when I evaluate somebody for a tongue tie, I'm looking at all of their symptoms, all of the signs. I'm looking at the craniofacial structure. I study, half a dozen to 15 pictures, videos that show me the airway, how the teeth are developing, what the arches look like, what the profile looks like, what their whole body posture looks like, all of that stuff. And then I have them do, half a dozen functional assessments. Can they elevate? Can they protrude? Can they lateralize the tongue sideways? There's so many different things. It's not about appearance. It is about oral function. And that's why a comprehensive assessment is so important, because your doctor may say, hey, stick your tongue out. Nope, you're fine. You don't have a tongue tie. And some doctors will say, well, unless you can't lick an ice cream cone and that bothers you, or unless you have a speech impediment, you don't need to do anything about it. And that's really not the case. So that is really, in a nutshell, what a tongue tie is. It's there at birth. It doesn't stretch. It doesn't just magically get taken care of, okay? It's a collagen fiber, so it's not going to just, it's not elastic. And then how to fix a tie. So let me touch on that here so it doesn't get missed. So that requires a simple procedure. Some people call it surgery, just depends. You don't have to be put to sleep for it, for sure. But it's called a frenectomy. It's done by a doctor. It can be done by a dentist. Some periodontists do it. Some ENTs do it. Some orthodontists. The biggest thing is it has to be done by the right person. And then it also has to have myofunctional therapy. So that happens for me in my practice about 2 months prior to a release. Okay. So, I'm going to continue on, but I just wanted to bebop in here and talk with you directly about what a tongue tie is. Okay. So let's talk about why tongue ties matter. It is impossible to achieve good craniofacial development when the tongue is tied down, period. The tongue can't live in the roof of the mouth and the floor of the mouth at the same time. So here in just a sec, I'm going to talk about oral resting posture. So I'm not going to get into that yet, but just know that the complete tongue, tip to tail, is supposed to live in the roof of the mouth. Next, I want to tell you that there are very few okay tongue ties in my opinion. A tie is a tie is a tie, okay? So when somebody comes to me and they say, well, I was told I just have a little bit of a tie, it's like being a little bit pregnant, okay? There's so much more to it. The thing is yes, I know we identify tongue ties based on functional impairment, not appearance and not the restriction. But in my practice, I have seen very few cases where it was just wait and see. I don't like that approach when it comes to the correct development of a child's face. I think that that's kind of a big deal, you guys. And many of you guys know this story, but this topic is very personal because my own granddaughter had a tongue tie for years, had a tongue tie, and for years, nobody even gave it two thoughts. She had 3 years of failed speech therapy. She had difficulty nursing. She had difficulty swallowing and chewing and swallowing food without choking. She was like sleeping with a gymnast. She was so restless. And she had a steady diet of medicines for congestion. You guys, the poor girl was 6 years old and she carried around her own nebulizer so she could take a breathing treatment. This is not okay. Now, as soon as I took my training, I knew what the problem was. She had a tongue tie. She since has had a frenectomy. She had successful myofunctional therapy with me, but guess what? Her craniofacial development was altered because of that tongue tie. So it matters. So let me just sum it up to say that when I say tongue ties matter, they have lifelong consequences for certain. So what can you do? What symptoms does your child have? I am always shocked when parents tell me all of the problems that their kid has, but they have never dug into them. They've just accepted them as the status quo. Now you can immediately get to work by finding the private eye list in your workbook. There's 8 pages, you guys, that are there for you. Start filling them out. I gave you the information. If you don't have the workbook, make sure you get it because that private eye list is going to be so important. Like I said, there's 8 pages. The next thing you can do is get second opinions. Get a myofunctional therapist that you know and like and trust to guide you. We are the first line of defense because we get it. That's our job. We are passionate about this and we get fired up. And a lot of us, like myself, spend tons and tons of our time educating, okay? We get it, you guys. Not all doctors do. There is a lot of misinformation out there. There's a lot of antiquated thinking out there. So let's talk about how to talk to your doctor about a tongue tie. Okay, so do they understand ties? How many do they do? What about myofunctional therapy? How do they assess? Not to be Debbie Downer here, you guys, but there is a pretty good chance that your doctor, pediatrician, dentist, whoever, might have zero ideas about tongue ties. Other than learning about it in school, many have little exposure after the fact. Okay? So I want you to ask questions. And this is the exact reason why I want people to start with a myofunctional therapist because we educate you. Okay? We don't look at you like you're crazy when you ask us questions. We don't look at you like you've got 3 eyeballs. Okay? So when your doctor looks at you like you've got 3 eyeballs and you're crazy, we want you to feel comfortable and have the knowledge to turn and run away. You need the right person for the job. You don't want them dusting off that laser from the back room that hasn't been out in a coon's age and offering to do the frenectomy. In all of my years as a hygienist, frenectomies were rarely done unless it was for a gum recession. It makes me so sad. So let me introduce you to Declan. And this is why I get so sad. So Declan was 11 and he was a hygiene patient of mine. So as you can see by this slide, he has an obvious tongue tie. Now Declan had been going to the dentist religiously every 6 months since he was 2. So can you just go with me for a moment to that place and feel what his mom felt like when I brought her back to my operatory to talk about his tongue tie? Can you feel her frustration when the new hygienist comes out and says, hey, there's a concern with your kiddo? So they knew something was different about Declan. The whole family called it a butt tongue, but they had no idea that it was a concern. And in my eyes, it is 150% unacceptable that Declan had visited a dental office 17, 18 times, all in the same dental office, not by one person, but the same dentist, okay? So he had different hygienists, but not one single person mentioned this. So again, talk about low-hanging fruit. Every single dental hygienist on earth, and really dentists, speech therapists should be talking about this obvious condition. They should be finding it and pointing it out. Now, I know that as a mama, we are just supposed to love our babies, quirks and all, but I am here to tell you that there are some things that you need to investigate. Okay, I got to simmer down here for a minute. Tongue ties, as you can tell, get me fired up. Okay, number 3, oral resting posture. Your child needs correct oral rest posture. And what is that? That is tongue up, mouth closed, teeth about 1 millimeter apart, and lips are sealed. The tongue needs to be up in the roof of the mouth, making contact with the palate to spread the maxilla out. The tongue is nature's expander. And also when the tongue is up and correctly positioned, the spot, which is a bump right behind the top front teeth, which is, that's a vagus nerve ending. When the tongue is correctly up, that is going to be stimulated. The vagus nerve helps regulate breathing, digestion, and anxiety, just to name a few things. So we want correct tongue posture. Tip to tail, the back of the tongue should be making contact with the soft palate and everything all the way across the top. Now, lips need to be closed as well. First of all, for nasal breathing, which puts an expansive forward growth on the face, but it also helps guide the teeth into place. Have you seen those big old buck teeth jutting forward in people who have open lips? When you part the lips, they lose their strength, and that leads to those big old buck teeth. And when the lips are open, the upper lip can become what we call incompetent, which means that it's been rolled up for such a long time that it's now very difficult, if not impossible, to bring the lips together at rest. So I kind of compare it to walking on tippy toes. So if you walk on your tippy toes for a long time, eventually the calf muscle is going to shorten, okay? So the same thing can happen with the upper lip. Another thing that can happen is having a chronic open mouth. Those can lead to an open bite because the molars will continue to erupt. So the teeth always want to touch each other. So if they're not, they're going to just continue growing to reach to touch each other. Well, eventually, when the molars come together, the front teeth aren't going to come together, and therefore you won't be able to bite into things, like you won't be able to bite through a sandwich. Okay, so what can you do? Start watching your child. From the moment that you have this knowledge, you need to be gently guiding your child. If you see them with the mouth gaping open, you need to remind Johnny to close his mouth. He may not necessarily understand that the tongue needs to be plastered to the roof of the mouth, but at least if we can get his mouth closed and get him nasal breathing, then we are making some of the most important changes. Now, parents don't want to harp on their kids, but I'm always saying, hey, we need gentle correction. So it's a lot like foul language. If your child was using a word that you don't approve of, you're not ever going to get tired of correcting him or her. So don't grow tired of providing gentle corrections. I have never met a child who has been scarred by that yet. It's important to model behaviors also. What's your mouth posture look like? Is your mouth gaping open? Is your tongue visible? Are you mouth breathing? What's going on? What are you showing your kiddo? Another thing that you can tune into is oral habits, okay? These are toxic for a reason. Anything in the mouth, you guys, is affecting correct tongue posture, correct mouth posture, and most likely breathing. Anything in the mouth keeps the lips apart and the tongue in the wrong spot. This includes pacifiers, anything, fingers, pencils. I've had kiddos that chew on clothes, everything, okay? And the other thing that you can do is deal with a tongue tie if there is one, and if your child is of the appropriate age. And I guess I didn't touch on that back in the tongue tie section. Generally, a child has to be, if the tongue tie is not because of a nursing issue, then a child needs to be old enough to comprehend, comply, and cooperate with therapy. So I'm going to bop back here on the camera and talk about that. So this is a hard thing because I get a lot of emails from parents that are like, well, Johnny is 2.5 and he has a tongue tie. What should we do? And I tell them that you should wait. And because what happens if you do it at an age that's not appropriate for your child, they're going to release that tongue. They're going to have some misery. It's going to heal right back down because they're not old enough to do adequate myofunctional therapy. They're not able to voluntarily control the muscles and do the work. So when parents disregard what professionals like myself say, they just set the child up for failure, because I have not met anybody yet who had a release at the wrong time and didn't need it done again. And that always makes me have the most unpopular opinion in the room when I'm saying, hey, you got to do this again. And so what can happen is, so we get the release, it heals incorrectly. We didn't have any of the rehabilitation, none of the prep work, none of the post-rehabilitation stuff. And now we have a kiddo who has a tongue tie again, has scar tissue, and they remember what happened to them. So some of them, they don't ever want to go to the dentist again, and we don't want that to happen. An extreme case also, we never want a child to end up with an oral aversion. I have consulted with parents where they say, hey, my kid had something traumatic happen at the dental office and now that child won't take in food. So has a feeding tube. So we don't want that. And so taking the time to understand rather than just go barreling into saying, hey, I have a kiddo and we need to get a frenectomy done. Now, there's a couple of extreme cases. And I've worked on some of those extreme cases, and it's mostly for children who have such a severe tongue tie that they literally can't get the tongue out of the floor of the mouth. Okay, we need to get some release there, knowing full well that there is going to be a point where we end up doing it again. I have had some younger cases of kiddos where parents are saying, hey, he won't speak. So there's a speech delay. So he won't speak. Will you please help us? And so we go into that situation knowing that it's not going to be perfect. But I think that should be the exception, not the rule, okay? So just because you go to your doctor and he says, yeah, I can take care of that next week, just because you have 5 children that all have tongue ties does not mean that you can go get them all bam, 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 taken care of, because it's a terrible decision. And that's really one of the reasons that I do this lecture, and we're going to talk about Mommy, Myo, and me at the end to kind of give you a bridge until that point. But again, that's not dealing with the frenectomy, okay? So I hope that makes sense. If your child is not of an appropriate age to be able to comprehend, comply, and cooperate with therapy, they should not be having the release. And if your child is not going to let you into the mouth to take care of that wound, then you need to hold off on that as well. Okay, I hope that is perfectly clear. Okay, I think We're ready to talk now about number 4, adequate and correct chewing. You need to encourage your child to chew. So, chewing real food creates good facial growth, you guys. And now, this has really kind of blown up since Dr. Stephen Lin's book came out, The Dental Diet. I get a lot of questions from all over the world of parents asking, questions about this. So, as parents, we are very often the person who can exacerbate myofunctional dysfunction. If you feed your child pureed food, smoothies, yogurt, etc., you can make those things worse. So I always encourage parents, especially those who contact me with really super young kids, to make their kids chew real food, okay? Let me rephrase that again. If you're a parent and you're reaching out to me and you've got a 2-year-old and you're saying, hey, what can I do because my kid's too young to do anything? I'm going to say, make sure that your kid is chewing real food. Make sure your kid is nasal breathing, mouth closed, all of those things. Now, with processed and ready-made food, that's all available, so easy to us. Kids don't work their muscles very well. Not to mention that parents tend to cook everything to death and chop it into little itty bitty tiny pieces. So what you can do, make your kid eat food. Food. Very often gagging, problems with textures, that can be caused by muscle weakness, also by a tongue tie. So you don't want to just overlook and say, oh, Tommy is picky. Okay? Many of my younger clients who have tongue ties discover that they didn't like certain foods because they were really difficult to chew because of a tongue tie. So pay attention to this. If your child is a rapid eater, doesn't chew food well, you can see it in the stool, or they seem very picky when it comes to hard to chew foods. If your kid hates the carrots and the pork chops and the chicken, all of that stuff that would seem like a lot of work, then I encourage you to dig deeper. Now, I want you to remember, good chewing stimulates growth. So a couple things, let me just touch on these again. Number 1, rule out a tongue tie, but remember, it's got to be age appropriate, okay? Make your kid chew. Stop processed, easy to eat food. This means minimize baby food or applesauce packets. Try and follow like baby-led weaning. Parents, stop making it worse. If Johnny's picky, don't give him a smoothie all the time, because I have had kiddos that are 14 years old and all they want to really eat are smoothies, applesauce, and chicken nuggets. That's not going to help your child, okay? And then don't cook it to death or cut it into little tiny pieces. All right, let's talk about nasal breathing, number 5. So nasal breathing is so important because really a few things. So it puts an expansive force on the face, okay? It cleans the air. It allows you to get nitric oxide, which is in the sinuses, and that nitric oxide helps the uptake of oxygen into the lungs. Nasal breathing is a healthier mouth, so less decay, less dried out gums, that red swollen, that kind of stuff, and better digestion and mental health. So mouth breathing is a slow, steady decline in health, okay? So first of all, can I just say you cannot have correct resting posture if you're mouth breathing? So there's that. That's real obvious. But also mouth breathing means that your kiddo is constantly in sympathetic overload, fight or flight mode. When you're running from the saber-toothed tiger, you're amped up, right? Who cares about digestion and relaxation and a healthy mood when you're about to get eaten by that tiger? But how does mouth breathing contribute to facial development? Because we are talking about craniofacial development here. So when the mouth is hanging open, the face grows long and narrow instead of more forward and up. So here's a great example. Long, narrow face, flat cheekbones, and this picture was taken at age 7. Okay. And can I just touch on looking at this picture when you go back to that constant fight or flight mode. So you've got the sympathetic nervous system, you've got the parasympathetic nervous system. This kiddo looks completely fried. And that's exactly what she was. She was completely exhausted, not sleeping well, not doing anything well, just never had any energy. So I'm going to back on the camera here. And so let's look at my craniofacial structure. So you can look at my narrow face, my vertical jaw angle. So I really should have grown down and forward, or forward and up. You know, we all should have really strong facial features. We should have strong cheekbones. We should look like a Disney prince, you know, because we're starting to just, as a society, because of the sad American diet, mouth breathing, all of that, we're starting to have these long, narrow faces. You guys probably already know this about me, but if you're new to me, you don't. I used to be the world's biggest mouth breather. I used to take 4 allergy pills every day just to nasal breathe. So I had to get control of the congestion so that I could switch over. So it's possible. If you can nasal breathe for a minute, you can nasal breathe for life. So, but mouth breathing is super duper unhealthy. So going back to mouth breathing, like I said, unhealthy. Your nose is meant to clean the air and provide nitric oxide, which helps that uptake of oxygen. So super important. So what can you do? Observe your child. Is it obvious? You would be shocked at how many parents I ask, so how does your child breathe? And they can't tell me. They have no idea. Does your child chew with the mouth open? You guys, this is not about poor manners. It's about trying to get some air, okay? And then also think about, are you contributing to the problem? Dairy, dust, pet allergies. You would be so surprised when I have parents that want me to help their kiddo, and the kiddo is so congested that they can't breathe through their nose. But, you know, Jimmy's allergic to Fluffy, the kitty cat who sleeps on his pillow at night, but mom absolutely will not take Fluffy out of the bedroom. So it's really hard because it makes me feel like, you know, then what are you hiring me for? So one of the first things that I must know when I work with a child is, can they nasal breathe? I have them demonstrate breathing to see if they physically can or can't do it. If they cannot do it, they got to see an ENT or an allergist or somebody to see what is needed. Sometimes allergy medicine is needed. My goal is always to work with clients and to get them off their medicines, but sometimes we have to do it just to break that cycle. Like in my case, I was taking 4 allergy pills. Many of my mamas don't want to medicate, and I completely understand that, but we have to find a weak link and just kind of start making changes there. So some things to look for. You can look for open mouth. Does your child have dry chapped lips? Can you see their tongue? Physiologically, it's really hard to nasal breathe when the tongue is low. Do they have a puffy appearance? Do their gums have a puffy appearance? Are they having dental health problems? Are their lips rolling out? So one other thing, I think now is a great time to, I'm going to back on the camera here, and I'm going to talk about the vicious cycle of nasal breathing, or of mouth breathing. So, you know, we breathe through our mouth because it's a backup system, essentially so that we didn't die off as a society or as a species the first time we got a cold when we were a baby. So our mouth is our backup breathing. The problem is something causes you to start mouth breathing, because we are born obligate nasal breathers. So something causes you to make that shift. And then sometimes it's just a habit. You never go back to it. Nobody ever points it out. It's never a conversation, anything. So the thing with that I call the vicious cycle of mouth breathing is because when you're breathing through your mouth, you're disrupting the oxygen carbon dioxide balance. And your brain senses that. So the alarms go off and your brain says, oh my gosh, there's too much CO2 going out the mouth, or going out the nose. But when it's really going out the mouth. And so the brain tells the nose, the goblet cells in the nose, to secrete more mucus, which creates more congestion, which makes it harder for you to nasal breathe. So that's a vicious cycle. Sometimes it can kick you into a congestion cycle, for 30, 40 minutes. That's hard, which is why sometimes you have to take a medicine to help break that congestion cycle so you can start nasal breathing, so you can decrease the congestion for us to even get started, okay? I have a lot of clients who are congested in the morning. So what does that say? Yeah, it's because you snored and you mouth breathed all night. I notice that I have a little bit of congestion kind of late morning after I go work out in the morning. So that just kind of helps you understand that, because sometimes I will say that to my clients and they learn it, but they don't hear it. And then finally they hear it and they go, oh my gosh, that's why I really need to tape my mouth. But again, or not tape my mouth, but get my mouth closed. Now, but talking about mouth tape, this is why I don't want you to just mouth tape, because you're not fixing the behaviors or the problems that are causing it. All you're doing is forcing it, putting a Band-Aid on a bullet wound, and it's not long term. It's not going to last, and it can really be scary to kiddos. Okay, let me see what else here. And then last, remember that if tonsils were removed or nasal surgery was done, deviated septum, swollen turbinates, whatever, and this goes for children and adults, if the obstacle is removed but the behavior is not changed, that has to be done, okay? So a lot of parents will say, yeah, no, my kid doesn't have problems because the tonsils were taken out. But if there's mouth breathing, you need to fix that. Okay, last, number 6, you guys, early ortho intervention. So it's important to schedule an early ortho visit. And this topic is probably the biggest thing that blows parents' mind, okay? Because it's quite different from the conventional route to ortho, especially if anybody's near my age. The way most of us used to do this was that you would get most of your adult teeth and then your dentist would say, oh yeah, you got your dad's crowding, you need to go see Dr. Bob, okay? So they sent you to the same person that they refer everybody to. So this happened around age 10 to 12 normally. But if you knew that by age 6, 80% of the growth of the maxilla and the mandible was already complete. By age 7 to 12, 90%. Girls tend to be ahead of boys. So a 7-year-old boy could be somewhat considered a geriatric patient in the world of ortho. So I talk with parents a lot about the advantage to the time-sensitive growth window and that you need to act early. The thinking about ortho is that it's no longer a rite of passage in teenagerhood, okay? It needs to happen so much sooner. And so if you're multitasking, if you're kind of just barely paying attention to me, I need you to come back to me, because we're going to talk about some pretty different thought processes here with ortho. So first, let's talk about talking with your dentist about the correct orthodontist referral. So you have to educate yourself about airway and airway orthodontics, okay? So this will help ease the conversation. Your dentist might not be one of those people who are operating with the new way of thinking. Your dentist might still be referring to the same local orthodontist at age 12, probably the same person that did, his or her children's ortho. But this was how your dentist was taught in dental school, okay? But here's what I'm here to say, you guys. Somebody has to stand up for your child. If you want your child to grow properly, you have to have a critical eye for the health of your child, and that is looking at the airway, that's looking at the craniofacial growth, that's looking at crowding, all of that stuff. You have to be an activist. You have to be an advocate and not be afraid to have the hard conversations, or not be afraid to go somewhere else and get second and third opinions. So let's talk about what you can do. This is the part that really makes parents go, what? And they just, when I'm talking with them, they just glass over. Their eyes just go cross-eyed because it's so different to them. So here's the deal. You must observe and watch for misguided craniofacial growth. Do not, please, I beg of you, do not look at crowded teeth and blame them on Jimmy's dad who has crappy crowded teeth, okay? Look at crowded teeth as a sign of not enough craniofacial bone growth. Now, Dr. Stephen Lin, in his book, he talked about the stadium concept. So if you have a stadium and it's not big enough for all of your chairs, then the chairs aren't going to all fit in there. The same is with your teeth. And that's the same with dental crowding. So grab your kiddo, have them come stand in front of you and tip their head back and look at their mouth, look at their teeth. If the baby teeth are touching you guys, there's about a tiny percent that they will actually grow big enough for those teeth. Our baby teeth are supposed to have what's called leeway and primate spacing, which are gaps in your teeth to hold space for the bigger teeth. If your child doesn't have those right now, guess what? There's going to be a concern. So if you notice that you've got a young kiddo, I mean, they're doing it age 3 and 4, they're doing interceptive ortho. First, you need to seek out an airway focused orthodontist. Now, I have a very popular blog. It's called Airway Orthodontics, Become an Advocate for Your Child. You can find that on my website. So I have that blog, but I will caution you, this is not the orthodontist down the street. Probably not. Probably not, maybe not even in your town. This is somebody who's going to look at your kiddo as a whole structural unit and not just cosmetically straighten the teeth. If you have a child who has misguided craniofacial growth, this needs to be your first stop, okay? So they're going to be looking at what is the cause? Is there an airway crisis? These exceptional orthodontists want to know why. They want to know why your child has issues. They don't want to just crank the teeth around and get them cosmetically in place, okay? So the difference between conventional ortho versus like airway ortho, face forward ortho, facial growth focus, orthotropics, all of that stuff. The difference really is conventional ortho in most cases is going to pull teeth to get teeth to align correctly, which we don't want. They're going to crank cosmetically the teeth into place. In my case, I had braces 3 times. Every single time I had, or not 3 times, sorry, I was getting them for the 3rd time when thankfully that orthodontist said, hey Carmen, the orthodontist is not your problem. You're the problem. And it was my mouth breathing, it was my tongue posture, it was my inadequate craniofacial development. So that's the thing. I had orthodontists that would shave down my teeth to make them fit, but because I didn't have enough room in my stadium, my mouth wasn't going to stay. And so that's the biggest thing. I'm seeing people in their 50s, 60s, 70s that are getting braces for the 2nd, 3rd, 4th time. They're doing Invisalign. They're doing all of these different cheap, easy routes, if you will. And they're saying, well, my teeth relapse. Or as soon as they take the permanent retainers off, which the permanent retainer is that metal bar, the teeth move. That was my case. My stadium does not have enough room in it for all of my teeth to be perfectly in. Now my teeth would be more crowded had that lovely dentist not shaved down the sides of my teeth, which anatomically made them smaller, but he just forced them in. So really the Reader's Digest version of conventional ortho versus like an orthotropic is they're going to look at, so conventional is going to be like straightening their rail cars on the tracks versus an orthotropic or somebody who's looking at you as a whole or your child as a whole structural unit. They're going to be saying, okay, well, let's look at the beds where we're going to place the rails. Okay. And then let's look at the rails. And then we get to the cars. So in those cases, oftentimes, I get put in as a myofunctional therapist. I'm right in the middle of the treatment because some of those treatments are, 2, 3, 4 years long. And so we have to do different things. Or sometimes I have to work with somebody at the beginning and then kind of take a step back in the middle and then kind of come back and finish it at the end. So the biggest takeaway message here is that there's a big difference. And oftentimes where your dentist refers you to, A majority of the time, it's just to their buddy old pal down the road who did their kids' ortho. May not be airway focused at all, may have those antiquated thought patterns, might pull teeth. You can't pull teeth out of a small mouth. They make a smaller mouth, okay? And then you end up with like the scenario of a 6-foot tiger, a 3-foot cage. So we don't want that. We want the face to grow forward. We don't want an orthodontist that pulls the face retractively back also, because that compromises the airway. Okay, so let's see what else. So let's talk about what parents can start to check out. So you have to seek out the right person. Yes, it's going to cost some money. Yes, you might need to travel. I have parents that travel to other states for airway ortho, okay? But your kid and their health are 100% worth it. Go read that blog, and you can search for it right on my website. But there are some great resources, and the world is small enough that I feel like if you called these offices and said, hey, I'm in Wisconsin, do you have any airway focused orthodontists here? You might be surprised just how small the world is. The other thing is, when you're searching your area for an airway focused orthodontist, if they don't talk about it front and center on their website, then it's not their specialty. It's kind of it's kind of like they're doing it now because it's the fad or whatever. If they don't mention myofunctional therapy, if an orthodontist is all just about the cosmetic part of it, they don't know about myofunctional therapy. They don't understand the importance of mouth breathing. It disheartens me to talk about the number of clients who have, I'm going to bop back here on the camera, the number of clients who have been sent to me, their kiddos getting ready to graduate from high school. Some of them have been in ortho or some variation thereof since first grade. And they get sent to me by their orthodontist that says, hey, can you fix this problem for me? I have this kiddo, Johnny, who hasn't, he's been in 3 rounds of ortho. He's had expansion. His bite keeps changing. He keeps getting an open bite again. Could you just help? He has a tongue thrust. A tongue thrust, you guys, is a symptom of a bigger problem, okay? It is not the problem. And a lot of orthodontists refer to me to fix a tongue thrust. Well, I need to fix the oral rest posture. That's the problem. But what happens when I'm getting these kiddos that have been in ortho for years and years and years? Parents have paid thousands and thousands of dollars, and it's so frustrating to me to get these kids that are, so many years in, and they're mouth breathing and they have a significant tongue tie. I just feel like that's amateur hour 101. Like, why hasn't this been screened for? So that is part of that passion here that I'm teaching you. Why? You have to ask questions, that in my eyes, those kiddos in first grade should have been screened for a tongue tie. Their orthodontist should be saying, hey, I'm not straightening your teeth. That really should be the last step in a lot of cases, because we should be correcting the mouth posture, the tongue posture, the nasal breathing habit, prior to worrying about cosmetically straightening the teeth. And so let me see what else here on my notes. Like I just said, a great airway orthodontist is going to be focused on getting your kid nasal breathing and having correct oral rest posture long before they worry about the teeth. So oftentimes that means I'm the first step. Okay. So now after all this stuff, you might be saying, so how can I make a difference for my child? Usually when I give this lecture, parents tend to be more freaked out than they are empowered. And I want to empower you. So number 1, watch for misguided craniofacial growth. Catch things early. Don't just assume that Sally Sue is as good as she's going to get. Don't just assume that Sally Sue is different, okay? Yes, I know we love and love our children and we're not supposed to pick them apart, but I encourage you in these cases, it's very worth it. Number 2, do not be afraid to get second opinions or third opinions. I don't care how many it takes, okay? Ask questions. To the orthodontist, ask them if they do retractive orthodontics. Ask them if they extract teeth to fix crowding issues. Ask them if they understand the concepts behind airway-focused orthodontics, and ask them if they believe in the philosophy. Ask if the orthodontist routinely uses extraction or retraction to solve problems, okay? If they do, then I would encourage you to move on. Find somebody else. You need someone to help your child grow properly, irrespective of the teeth. When you extract teeth from a small mouth, you get a smaller mouth. I've already said that. When you're talking to the tongue tie doctor, ask them questions, and I already had that on a slide, like how many do they do? What's their process? Do they even mention myofunctional therapy? What's their opinion about tongue ties? What's their method? All of that stuff. It doesn't necessarily how they do it. I'm not worried about the tool. I'm not worried whether it's a scalpel or laser. I want to know their brains behind it. And generally, my opinion is, unless they mention myofunctional therapy, probably not going to have a great release, because that's where we get the success. Okay, number 3, see a myofunctional therapist sooner rather than later. So the first step will be to have your child completely assessed. This will include the assessment of breathing, sleeping, chewing, swallowing, speaking, posture, all of those things. A myofunctional therapist will complete this assessment and be the hub of the wellness wheel. Your child will need a comprehensive health team, and your myofunctional therapist, it helps create that. And that is always what I tell parents is, I'm there to help take some of that overwhelm off so that you know kind of what steps you're supposed to go through. All right, let's recap. So I just taught you guys 6 things that parents need to know about craniofacial development in your child. Number 1, airway awareness. Your child needs air, okay? Air trumps everything. I don't care what the other concerns are. We have to know about the air first. Number 2, tongue ties matter. They need to be diagnosed. They need to be fixed. Just remember, it needs to be age appropriate. Number 3, oral resting posture. Your child needs correct oral resting posture. So unlike this picture, we want the tongue up, completely sealed across the roof of the mouth into the soft palate, tongue up, mouth closed, teeth gently apart, so about 1 millimeter, and nasal breathing. Number 4, we need adequate and correct chewing for your child. That means encouraging them to chew food, capital F-O-O-D, not eat applesauce packets and smoothies. We don't want them drinking their food. We need them to chew. Number 5, your child needs to be nasal breathing. And number 6, it's important to schedule an early ortho visit. And remember, not just with any orthodontist. So it's not going to be just the one down on the street corner. Okay, so one question parents always have is about getting started. So first, I always say investigate. So use your private eye list that's in the workbook. There's 8 pages. Use those to identify areas of concern for your child, because that's the first thing that I want to know about somebody, so that when somebody moves on to schedule that free assessment with me, we use that time to answer questions. I want to make sure that it makes sense to go move to a paid exam, okay? When somebody does that free assessment with me, I'm asking for a discovery checklist, which goes over all of these symptoms. So all those things that you're going to mark on the private eye list, those are things that we talk about. I never want somebody to move on to a paid exam and then me say, you're fine, just kidding, you don't need me. Because it's never happened, but I never want it to. Next, an exam. So this comprehensive assessment allows me to understand what's going on. I can learn about the impairments, and I use that information to best plan therapy. And then after that, then your child is ready to start therapy, okay? Let me get out of the way here on my slide again. So I've talked about this, the parent private eye list. So there are 8 pages. Here's a simple question. Did your child have breastfeeding difficulty? Did your child have to be bottle fed because of those problems, or milk supply issues? So it really helps you to start unpacking. Some other resources, you guys can find this on my website. The Ultimate Guide to Tongue Ties, The Ultimate Guide to Myofunctional Therapy, The Ultimate Guide to Sleep Disordered Breathing, The Ultimate Guide to Breathing. Okay, so now we're going to talk about you can introduce Myo-based games. And so this is where we're going to talk about Mommy, Myo, and Me. So this program is our popular bridge program. It shows you exactly how to give your child a head start on myofunctional issues by implementing a fun, game-based exercises or activities that really the whole family can benefit from. Now, disclaimer, this program is not meant to replace traditional myofunctional therapy or any other help that your child needs. If your child has an airway crisis issue, this program is not going to solve that, okay? This is an educational program, not a therapy program. So it's meant to tide you over. Remember, I don't know anything about your kiddo, so it's meant to just give your kiddos a head start. In this educational program, you will strengthen the weak muscles, you'll build coordination, you'll identify poor habits, you're going to create positive habits, build lifelong skills, and also have a lot of fun. So in this program, when you enroll in Mommy, Myo, and Me, you get 10 at your pace lessons. And this is meant to give you a lot of tools for the tool chest when it comes to helping your kid get a head start. So how it works is that these 10 lessons, when you enroll, the lessons arrive by email. You will receive a new lesson every 2 weeks. There's instructions, tips, tricks, hacks, frequently asked questions, all of that stuff. This happens, every 2 weeks until the education series is complete. I also send you the Parent Success Guide. And so right there's the enrollment information. It's $297 right now. Depending on when you watch this video, it's hard to say. That price may go up. So just know that, sadly, that's, I guess, how it works. Like I said, each lesson will be 2 weeks apart. But really, in real life, you're going to work with your kiddo much longer on these different exercises. This is not meant to be therapy. It is meant to give you tools for the tool chest, okay? And so in my mini Myo program, I work with kiddos for about a month on things, but the reason that these lessons are delivered 2 weeks apart is so that if you've got a kiddo who can't do, some of what comes in lesson 1, guess what? Something's coming from lesson 2. And then, pretty soon you're going to have like a big grab bag. I have some parents that just put names on, or, like the name of the game or the exercise on a card, they put it in the hat and that's what they pull out. So it's not meant to replace therapy. That's the biggest thing. It is just meant to give you stuff so that you can work on the strength, the coordination, all of that stuff with your kiddo. Right here on the screen, it does show my email. You also can enroll in that on my website. And then on my Instagram, my link has a button there also for that. So if you have questions, please reach out to me. This program came about because Dr. Stephen Lynn's book, parents would contact me. I would say, your kid's not old enough. And then parents would say, what? You're telling me that there's a concern and you're not helping me with it. So that's why this education program is there, just to help you. Things that you're gonna, it's something that you can do at home. You don't need special supplies, that kind of stuff. And if you do, it'll be something that you have at home. So let me know if you have any questions. I really appreciate you being here. I think that is it. So let me know what you thought about this. I hope you had your workbook, and I'm curious to know what you found out with your private eye stuff. So I'm going to let you go. Thank you so much for taking the time to be here. I really appreciate you.